I'm Abhishek Shrivastava from India. So let's just stay in tracks, make it more broad and make it more overall. What is telemedicine? And how can we use telemedicine overall as a principle in your rehab, assessment, planning, and follow-up? I come from Mumbai and we work in Kokilaben Hospital, the largest corporate hospitals in India. So we are in Europe, and we can say the cost of European economy in conditions will be 798 billion euros because advanced aging, brain injuries, Alzheimer's disease, spinal cord injury, the cost is piling up. And 1 billion people worldwide need neuro rehab services, and 2/3 don't receive any rehab after discharge. Current scenario everywhere in the world. We all know acute care hospital, rehab hospital, outpatient clinic, go home. How many come back for follow-up? We don't know. But in most of the places, people actually go to home straight away. They never get rehab. So what is telemedicine? It means distant healing. Greek word tele means distance. Mediri means to heal. It is no specific technology, but it's a way we can use technology from a distance to use for medical expertise and provide computer science care. It is the future of global healthcare. Just some history. 1999, first time Enagran produced some paper on telemedicine. Then the first 3 systems in America and Europe which used telemedicine were prisons, rural healthcare, and radiology, because they can't take prisoners to the hospital, so they're the first to use actually telemedicine. And then in 2006, first time someone published that it's a good way to make money for the hospitals also. And they suggested that people with disability should get the opportunity of telemedicine for long-term care. So there are 3 different terms: telemedicine, telehealth, and telerehab. Telemedicine is to use technology remotely to diagnose, monitor, or treat patients. Telehealth is the application technology to help patients manage their own illnesses, to improve self-care, access to education, and support systems. And third is telerehab or e-rehab, which is delivery of rehab services over telecommunication networks. So we all work in different spectrums, and it helps all types of patients. So what happens in telemedicine consult? What's the program? It's very simple. We have a hardware, we have a software, you have a connectivity. In the hardware, you require telemedicine platform, a clinical device to attach to that, a video conferencing unit system, and communication hardware. Software, you can buy your own software, customize your software, you have good connectivity with good LAN and cable speed. We discussed about that. Simple concept, you should have a CPU, a display device, a video camera, telecommunication link, and a software. These 5 is available in most of the hospitals, centers, everywhere in the world. So, very important concept. You can do something, do we have a laser marker here? Yeah. You can do something in the remote, you can do it in person. So in remote, when video examination, when physical examination is not required, we can do a remote type of thing to diagnose or treat patients. When physical examination is important to treat a massive infection or a sprain or cut or a fracture or a stroke patient, TBI patient long term, to do an in-person thing. But now you will have a virtual emerging area of healthcare where you can actually monitor long-term chronic diseases online without coming to person. So you can do 3 basic things: remote, in-person, and emerging concepts. Most important slide. You can do 4 things. You can do a professional consultation, you can diagnose and treat, you can do education and engagement, and you can do ongoing monitoring and care. 4 things are possible with telemedicine. And you need, the 5 different systems are available. First is a video conference, we all know. Second is a asynchronous system, you record and use it later. Third is a remote device. Fourth is a telephone. Next is a patient portal. Last is a mobile app. These 6 things are available. Each have their advantages and disadvantages. The most commonly, but to get a simple concept, you can do a consult with a video conference or with a telephone, which is widely available. You can diagnose and treat with a video conference or with a recording system. You can do education and engagement with all these 2 types of concepts. So no need to have all these 6 things: simple mobile phone and a simple conference system is good enough to diagnose, treat, and monitor patients in long term. Another concept is, one is real time, which is called as asynchronous. Second is store and forward, asynchronous. What is the difference? In a synchronous system, real-time system, both the parties should present same time. So the patient and the clinician, they are at the same time. You can use a peripheral device like a teleotoscope or a telestethoscope, which is possible. In an asynchronous system, you get information, you store it, you can use it later on. Mainly used for medical data, primarily for radiological applications. So we can use telemedicine for home care, ambulatory care, remote consultations, medical education, public awareness, secondary medical opinion, telemedicine procedures, even surgery can be done by robotics now, and disaster management. A lot of application there, telemedicine now. Advantages, you can use resources in a more effective way, early intervention, unnecessary transportation to be avoided, especially in neurological patients, can be used with community-based care, use medical education research, you can save cost, improve your documentation, and better range of education care. In India, let's have to talk about Dr. Surya tomorrow on that, but just to touch base, in India, 75% of qualified physicians practice in urban areas, 23% in semi-urban areas, 2% in rural areas, versus 80% population is in rural areas. This needs innovative methods to use telemedicine and tele-rehab to help our population. Actually, in India, there's a big network from ISRO, from Government of India, where they have telemedicine network, rural network, tertiary care centers, a lot of things are there in India for that. But I will talk mainly about what we do in our hospital for that. A lot of barriers are still there. Bandwidth is increasing. Electricity coverage in India was not very good, but this current government has now got 100% electrification in India in the last 5 years. State transmission is very expensive. Patients still have some fear and familiarity using a device. Financial viability is a concept. Quality aspect of the video conference is a problem, and government support still is lacking. So what we do in our hospital? I come from Bombay, which is in Western India, in a state called Maharashtra, and Mumbai is a red dot. I work in Kokilaben Hospital, a 750-bedded multi-specialty hospital, the largest rehab center in a private hospital in the country. So what we do, we're a center of rehab, and we have multiple rehab programs, including neuro, cardiopulmonary, pain, pediatrics, spinal cord, geriatric cancer. In neuro rehab, we have our intensive care unit, a stroke unit program, acute inpatient rehab programs, daycare programs, outpatient care, and home-based care programs. We have full team possible available, including a music therapist to help our patients, and we have all technologies possible available. We use 6-6-6 concept, which means we treat patients for 6 hours per day, 6 days a week for 6 weeks in the first 3 months period. That's how we are able to deliver good results. Some consults, actually the numbers are very important to understand the concept. We are very few rehab hospitals in our country, in India, very, very few. And we actually see about 3,500 new patients for rehab every year in last year data, and we admit about 2 patients every day for inpatient rehab care. How it is possible? Telemedicine provides healthcare where there is none and improves the healthcare where there is some. So it works for every level, whichever is possible. So simple slide to show, our 50% of patients come from Mumbai, then 50% come from North and Central India. This is 1,000 kilometers north-south, 1,000 east-west. It's not easy. So these patients, because of the lack of rehab service in these places, they come to us for rehab. How to connect them, we'll talk about it later. Even from North India, South India, this is more than 2,000 kilometer distance people come. If you travel by train in India, it will take 2 days to come to Bombay in the train, 2 hours flight. It's not easy for disabled people to come so long, but they still come. We need a way to connect to them. And we get patients from Middle East, a lot of patients from UAE, Saudi Arabia, Yemen, Oman, Pakistan, Nepal, Bangladesh. We get patients from even Middle Central Africa, mainly from Nigeria and Kenya. Sometimes to show patients from different countries are coming to us. So the important concept is to be in touch with them, how to screen them when they come. So what happens? Take a simple example with Telemedicine Center. So we do a video conference, we do an email, we do a WhatsApp, and we do a telephone. We do for consults to screen patients who come to us for rehab, be it from India, out of Bombay, out of Maharashtra, Central India, South India, Middle East. Simple example, lady sent an email to us. I am working in London, my father had a stroke, they are in Delhi, we want to come to us for rehab. We have standard format, how do we respond to it? We respond in a specific way, what we will do, what the program we will have for you, the costing, the time required. But there are many companies actually which work in helping patients to get to rehab centers. So this is a company which sent a patient email from Middle East. We have a patient with this problem. Can you help them? Again, we give a response, send a summary to us. We responded to them, whatever care we can provide to them, and then patients come accordingly. Another patient has come from North India. A simple example of email is a very, very potent way. This patient sent a whole video to us. We sent a video of him. I'm like this at 6 months post-stroke. Help me. Can you help me or not? This came on WhatsApp. So WhatsApp is a very, very, very potent way with email to help our patients. Another patient whom we treated 5 years back. We did the intravenous pump for him. He never came follow-up for 5 years. Now they've emailed us back with the video. He's like this now. Can you help him again? I told him, sorry, I'm going to Italy. I'll come back and see you next week. So WhatsApp, email, video conference are the way to screen these patients, tell them what is possible, is it worth coming to us or not, what program can you do it for them, will they improve or not. If I have own consult, patient we discharged about a few months back. He was admitted in a local hospital. Now, family told bilateral strokes, bad conditions. We're doing a secondary consult from our hospital chamber with the patient's family in local hospital. Because he had another episode of encephalopathy, thought a new stroke or not. Come to Bombay again. I told him, don't come to Bombay. We saw the local doctor there, saw the report, tell them, no, it's okay, no need to come. You manage there locally only. A simple happening on my iPhone, that's all. Now, lady of a patient, she had recurrent strokes. She gets bottle toss injection every 4 months for her severe spasticity. Before she comes, we do a consult, we just see what current levels are there. Then we decide. We are coming to Bombay. Once it was not that easy for everyone to come. It's a big distance, big country. So we screen them, all these patients, we plan, then we get them. And do all our follow-ups mostly on Skype or a video chat. This guy running a marathon, had a stroke, and then he came to us for rehab, and now discharged like this. So this lady, she lives 1,000 kilometers away from Bombay. How she was postpartum cardiomyopathy stroke 1 year. Now every year she sends the video to us. Whatever guidance our whole team sits there, we tell them what is best possible for you. Our OTs, PTs, physicians, we all sit together, tell them what further you can do because they can't come for simple things to us. But at least we're able to monitor them every 6 months or a year, a regular follow-up, which is very, very important. But they will require care for life. Another patient, very, very bad hemorrhagic infarct. 1 year was like that, 3 years going to work now. So every year we have a fixed day, we say that they are discharged on that day. They will email us or WhatsApp us the basic records and we'll see them again, talk to them and take it forward. Another patient with Eplas, bad ICS stenosis, at discharge he was like this. At 4 years, joined college now. I can't show the video here. Whole concept is you can screen patients who are eligible for neuro rehab. You can screen for follow-up and monitor their progress in long term. Another boy who came from Delhi, another kilometers away from Bombay, at 1 year, at 4 years now, he's able to walk now. So every year we do these follow-up routinely with these patients. And very important concept is awareness, which we forget. So we should be able to spread the knowledge that things are possible in rehab. Again, to propagate the concept of rehab, education is very important. We are writing articles to help these patients to understand that rehab is possible in chronic stage also if they get proper treatment. So telemedicine has a huge potential, and McKinsey says that 40% of in-person outpatient consults in India can be avoided in next 10 years. That can save $10 billion for our country. And it is possible by 2025, 60% of outpatient consults in India can be avoided in person if we use the technology proper way. Telemedicine is very powerful to create awareness. patient education, family education. Very important rehab planning. Is it worth coming to a rehab center or not? Very, very important concept. Regular follow-up, no need to come. It's a save money for everyone, reduce cost, improve data collection, and very important, research collaborations with different people. So the whole concept of rehab earlier was disability management, compensation, learn non-use. We're not on target impairment. If we target the impairment, we get better recovery. And if we screen them, if we follow up with them, better outcome in long term. Someone said, Eric Topol said, if we scale telehealth system to full potential, it will become dominant way the outpatient care is rendered. But Arthur Clarke, you all know him, what he said, before you become too entranced with gorgeous gadgets and video displays, let me remind you that information is not knowledge. Knowledge is not wisdom. Wisdom is not foresight. Each grows out of the other, and we need all of them together. Thank you very much.
Thank you very much. That was great. You have finished very early, so we have loads of time. I'd just like to ask, you showed us some really great videos there of patients who had gone home and then were sending through videos. Were they able to access therapy once they went home, so they did have ongoing treatment?
So what we do, when we discharge patients, we give them whole therapy programs, and generally 6 months we do a review, and in the review, even if advantage is that the whole team is not available at that time, if the video comes in time, we can even sit backhand, analyze it, then you have therapy programs, they can do it locally. So it is not important for them to come for simple examination when we can share it on our video application. So we give them a program to follow, which they can do at a local place.
Excellent, great. Okay, I'd now like to open up questions to the floor. Yes, we have one there.
Thank you. It's Anba Subramanian from Spinal Cord Injury, Mauritius and UK. This has been fascinating. Thanks a lot for sharing your experience. I've got two questions. One is that you draw upon very international people who come to you. Are you able to cope with the numbers? And second, what is the cost to the patient if they access your services? Is cost a limiting factor, or is it totally free?
So we are a corporate hospital, but we are not for profit. Cost is a concern, but we have a lot of schemes to help poor patients. So generally, cost is not a factor for most of our patients. We're able to access funds for them, those who can't afford it. Second, how to cope up. It's a difficult job. We are 2 rehab physicians who are consultants, and we have 4 registrars, and we actually see 80 patients every day. It's not easy. It requires 12 hours, 6 days a week. It's difficult.
Since the mic is just next to me, so I take the privilege to go first. Thank you so much. That was a really good a project. But my question was, with the outpatient follow-up, when they're discharged, how often is the follow-up? And is there a time period when you say now the patient is discharged from your follow-up through telerehab?
We are doing it for the last 5 years, and no patient discharged till now. Those who have milder strokes or milder brain injuries, don't require a lot of work, are discharged. But most of our patients who come to us are severely injured people. And so in the last 5 years, all of them are in regular follow-up with us, at least once in 6 months.
And how do you, I'm just intrigued for my education, how do you organize these MDT, remote follow-ups? Is there a time during the week that's set up and the MDT sits and then...
Yes. So that's why I'm saying it's not necessary for team to sit at the same time, because it becomes difficult. So if you have a videos and you have some conversation recorded with that, we have a day in a week where we all sit together and discuss those different patients. And then one of our secretaries make the notes, And then we customize some rehab programs with the photographs and a lot of literature about that, which are emailed to them. And they can do it locally.
Thank you very much.
Good morning. Thank you very much for that very comprehensive lecture and the sharing, okay, that you've given us. I'm Dr. Ray Matias from the Philippines also. I'm also with the Asia Oceanian Society for Physical and Rehabilitation Medicine. I don't know if what we have in the Philippines will also be true for India as well as for the rest of the world. Our main limitation brought about by our law, the law of it's called the Medical Act, and it's the Medical Act of 1959, so the very old, not yet revised, that there should be a face-to-face first encounter, okay, between the doctor and the patient to establish an actual medical consultation or something like that. And when it's translated to telerehabilitation, telerehabilitation can only exist if there will be a previous or a former face-to-face encounter. Okay, that was provided by our act, by our law. So that brings us a lot of limitation. For example, patients in the community never been seen first, okay, by our doctors or a doctor in our institution who wants to seek teleconsult, okay, to us. So I don't know if that will be the case in India as well as for the rest of the world.
Teleconsults are allowed in India. I said there is no problem with that. We are able to, it's always second opinion. It's never a primary opinion. So a video I showed, that patient admitted in a small nursing home in a distant place. We spoke to local physician at that same time. So it is not, if it's a second opinion consult for a medical reason, local doctor has to be there. If it is only for rehab perspective, doctor is not required to be there.
So I answer to that. Of course, again, I'm Nirmal Surya. To answer your, I agree with you, and 3 months ago, the Supreme Court of India has passed a law not to give any medicines on email or on WhatsApp or on telephone. So now you cannot give any opinion about the treatment without seeing a patient on phones. So that's been valid now 3 or 6 months ago. Now, you know, India is a very large country, and Abhishek has already shown you things. There's one concept which we started, family-based rehabilitation, largely to tackle, and this was originally I started in 2003 in Mumbai, because people cannot come to the Mumbai. And to answer you, India is a hub for the international people coming, not only from Asia, but from the Middle East and Africa, as well as many of the Indians and Asians settle in UK. They come to I see on an average 10 patients a year from Mauritius. Because one is, it's very cheap in India. The doctors are very cheap. The treatment cost is very less. And they can trust Indian doctor because Indian doctors are available practically everywhere in the world. So they have a faith. So that's the reason they come to India, and that's the reason any big hospital or center they would like to come and take the treatment. Now, to answer you, what we devised with family-based rehabilitation is that when we see a patient first time with the rehabilitation, we make a video there. The therapist explained to the relatives that this is what is the exercises you have to do. And I have told the therapist not to give more than 4 exercises, because too many can create a problem. Then what they do is, we tell them that you do it for 15 days at home. You do a video of what you are doing. And after 15 days, send it back to us. Or when you come for next consultation, say after 1 month, bring exactly the video of what you are doing. The therapist evaluate that and tell them that here you have gone wrong, here you have gone wrong, this is what exactly you have done correct. So then they add 2 more exercises or 4 more exercises, and correct what they have not been doing. So this is practice what we have been following with now the tele-rehabilitation. And I think this is getting much better result because you have two-way communication with the patients. Patient sends you video. The only problem comes is on the WhatsApp, we are not able to send a bigger video, more than say 20 MB or something, and that's creating a problem. So that we are trying to work out to get 30-second video. Thank you.
Thank you.